Hey, thanks for watching today. Here we're going to review the assessment and medical management of seizures. Health services across Manitoba are provided in facilities on the original lands of First Nations and Inuit peoples and on the homeland of the Métis Nation. Manitoba's health authorities respect that the First Nations treaties were made on these territories. We acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. This presentation is intended as general information to broaden the knowledge base and informed practice of paramedics across shared health. The goal is to ensure paramedics can utilize the knowledge gained and apply it to any patient care map updates. A seizure is a transient occurrence of signs and symptoms of abnormal, excessive, or synchronous neuronal activity in the brain. So let's do a little review of the A&P, pathophysiology, any clinical presentations we might see, and the management we're going to provide. We all know how complex the brain can be. This is an organ that works to control any motor skills and problem solving, hearing, language, and memory centers, breathing, heart rate, sleep cycles, eye movement, the balance and coordination of a person, the ability to see, sensory perception, and anything else that relates to regulating our bodies. When looking at the composition of the brain, the organ is not a muscle. It is mostly composed of fat, which contains blood vessels and nerves, and can also be divided into gray and white matter. White matter is a lighter intersection of the brain, and white matter is mostly made up of axons wrapped in myelin. While the gray matter, the darker portion, outer portion of the brain, is primarily composed of neuron somas. The different parts of the neuron is what gives each matter their separate shades. Now going a little bit deeper, let's look at the neuron. A nerve cell that transmits and receives electrical signals in the body via specialized connections called synapses. The neuron is the main compartment of the nervous tissues. There are three types based on their functions. The sensory neuron responds to stimuli that affects the sensory organs, for example, touch, sound, or light, sending a signal to the spinal cord or brain. Motor neurons receive signals from the brain and spinal cord to control everything, for example, muscle contraction or hormone excretion. Interneurons connect neurons in the same region of the brain or spinal cord, and when multiple neurons are connected together, they form a neural circuit. The soma is the body of the neuron. It contains the nucleus, and most protein synthesis occurs here. The dendrites are cellular extensions of the neuron with many branches, and here is where the neuron will receive the signal from other cells and other nerves. Then the signal will travel down the cell body and continue down the axon. Along the axon, there are Schwann cells that are covered in a myelin sheath and help conduct the nerve impulse along the axon. The nerve impulse will continue on and finally reach the axon terminal. Here, looking closer at the electrical impulses, a balance of negative and positive ions inside and outside of the neuron determine if the neuron is at rest or if that neuron is working and sending messages. Ions are chemical messages with positive or negative charges that cause the electrical message to be sent by the brain. When a neuron is at resting potential, then the charge within the neuron is more negative than the outside. When the neuron is working, its action potential is engaged through the change in the balance of positive and negative ions. This message causes the body to involuntarily or voluntarily move, feel, or behave. So therefore, the neurons are electrochemical messengers of the body. At the axon terminal, where two neurons meet, is a synapse, and this is where intracellular communication takes place. Neurons communicate with one another through action potentials, the changes in neurons' electrical potential, and through neurotransmitters. When an action potential is triggered in a neuron, it travels down the axon and causes neurotransmitters to be released into the synaptic cleft, which is the gap between neuron A's axon and the neuron B's dendrites. The neurotransmitters travel across the synaptic cleft and attach to the receptors found on neuron B's dendrites. So essentially, synapses convert the electrical signal or the action potential into a chemical signal via neurotransmitters, and then back into electrical signals once it meets the next neuron. So let's look at this process just a little bit more. When looking at the chemical part of the messaging, there are two types. The bulk of the brain's neurons are excitatory. So when they fire, they activate another neuron and propagate electrical signals throughout the brain. Inhibitory neurons do the exact opposite. They restrain or inhibit other neurons, making them less likely to fire messages of their own. The excitatory neuron will send an excitatory message, which is a signal to create a reaction in the body, so an excitatory reaction. This is when the chemical neurotransmitter glutamate is released from one neuron to another. At the same time, the signal in another set of neuronal networks is creating inhibitory signals. This is when the neurotransmitter GABA is released. And when the signals and neurotransmitters are being released in balance, there is a balance within the body. Are you still with me? I know that was a lot, but now that we know how things work, we can understand better what happens when things are broken. A seizure is a sudden malfunction causing the neurons to fire electrical signals uncontrollably. That causes a domino effect. This means that more and more neurons can go haywire. The more malfunctioning neurons, the greater the effect of the seizure. If they keep happening, or if this keeps happening and the seizure lasts too long, these electrical malfunctions will damage and destroy your brain cells. So not all seizures are alike. A seizure can be a single event due to an acute cause, such as medication or a trauma, or seizures can also occur due to a seizure disorder, such as epilepsy. So seizures are the primary symptom of epilepsy, but patients who have a seizure don't necessarily have epilepsy. Hope that makes sense. So back to those neurons. When there's a normal balance of neurotransmitters being released to control the body and its functions, all is well. When the message isn't communicated to release the neurotransmitter GABA, there's an imbalance, allowing more excitatory messaging to be signaled compared to inhibitory messaging. This overstimulation of the area in the brain with non-communicating GABA inhibition will lead to seizure activity. So why are the neurotransmitters so important? We'll get more into this in a few seconds. So who can be affected by a seizure? Well, anybody. We all have the same anatomical structure and functions, and we all have a threshold as to when the body will experience these seizures. It will be the cause or the structural difference that will be the difference if you or I experience a seizure. So the causes of seizures can be anything that disrupts the communication pathways. Some types of seizure disorders may be caused by genetic mutations. The most common cause of seizures is epilepsy, but not every person who has a seizure has epilepsy. Sometimes these seizures can be triggered by things such as high fever or infections, especially those infections that are affecting the CNS. So that would be our meningitis, encephalitis, anything that really triggers the brain or targets the brain. Hypoglycemia, we know that the brain loves sugar, so lack of sugar causing seizures. Use of illegal substances or alcohol. This could also be triggered by the withdrawal of these substances, as well as being sleep deprived. We have flashing lights, moving patterns, or visual stimulants that can cause the seizures. Other things such as low blood sodium, so hyponatremia. This can happen during diuretic therapy. We know that the voltage-gated sodium channel helps move the signals along the neuron axon, so when we don't have enough of those ions to trigger the movement of the signals, chaos happens. Medications such as pain relievers, antidepressants, or even smoking cessation aids, these are all known to lower the threshold for seizure activity. Hypoxia, because we know that oxygen is important to vital functions. No oxygen, no brain function. And severe gestational hypertension that causes eclampsia will also cause seizures. We talked about the acute causes, but seizures can also be caused due to chronic conditions as well. Epilepsy can happen on its own, or it could be caused due to another pathology that has changed the brain structure. It can be caused by those traumatic brain injuries that cause areas in the brain to bleed, any abnormalities of the blood vessels in the brain, strokes, especially those that are hemorrhagic in nature, and brain tumors can cause seizures as well. So when we break down a seizure into stages, there's 4 that we're going to discuss, but it is important to note that not all stages will be present during every seizure. So for the prodromal stage, this is when symptoms start to occur before the big event. This could be the onset of a person feeling depressed, feeling anger, or other mood changes, issues with sleeping, anxiety developing, even GI and urinary changes. These symptoms typically begin days before the seizure. So we're all kind of familiar with that aura stage of seizures. We know that it doesn't happen with all types of seizures. It will happen at the very beginning of a seizure, kind of as a warning sign that a bigger seizure or event is coming. And this will happen within seconds or minutes, different from that prodromal stage that happens days before. Often patients know their aura and will know how to prepare themselves for a seizure by making themselves safe, lying on the floor, even calling for help if there's time. People can experience altered vision or hearing, increased anxiety, confusion, distorted emotions, a sudden weird taste or a smell, experience vertigo, numbness, and even the inability to speak. Then there's the ictus stage. Ictus meaning seizure. So typical seizures last from 1 to 3 minutes, a really important distinction. So always time the seizure or gather as much information from bystanders on the length of time as possible. This is because if a patient has a seizure lasting longer than 5 minutes or multiple seizures without regaining consciousness, they have entered a state of seizure called status epilepticus. This type of seizure will not stop at all by itself and will need immediate medical intervention to make the seizure stop. And then finally, the post-ictus stage. This is the recovery after the seizure, when the brain takes time to recover and heal from the seizure. How this stage looks for each patient varies depending on the seizure type. From immediate recovery if the patient has experienced an absent seizure to even hours or days if the tonic-clonic seizure the patient is recovering from was extensive. Very, very tired, patients wanting to sleep. They seem lethargic, confused, complain of a headache, or they might actually have evident injuries due to the seizure. So we all remember these terms and trying to remember what type of seizure someone has had, but now they generally classify seizures as either being focal or generalized based on the abnormal brain activity. Seizures can also be classified as an unknown onset if how the seizure began is not known. Seizure types depend on where they happen in the brain, and we can determine where they happen based on symptoms. Seizure locations tend to happen in 2 main ways. The generalized, these are seizures that happen on both sides of the hemisphere of the brain, and the seizure tends to cause more severe effects and symptoms. Focal seizures, also known as partial seizures, these happen in only one hemisphere or the other. That means symptoms only happen in a specific part or on one side of the body, but focal seizures can also sometimes spread and become generalized seizures. So again, important to investigate how the seizure started and how it's progressed. For those unknown seizures, either of these can lead to status epilepticus, right? Status epilepticus happens when a seizure lasts for more than 5 minutes or you have more than one seizure without enough time between to recover. Status epilepticus is a life-threatening medical emergency because it can cause brain damage and even death if the seizure is not stopped. An aware onset describes seizure instances in which the person is awake or aware during the seizure. And an impaired awareness onset differs in that the person is confused or their awareness is affected in some way. Looking at generalized seizures involving all areas of the brain, the patient may experience an aura, or there may be no warning that the seizure is about to happen. Limbs on both sides of the body begin to jerk and shake and contract. This is known as tonic-clonic. A patient's awareness and responsiveness is lost completely. The entire body becomes stiff. This is known as the tonic part. And the entire body loses the tone, causing collapse. This is known as atonic. Incontinence may occur. A patient can bite their tongue or the inside of their cheek, so you might see some blood in the mouth area. Breathing affected can cause cyanosis or the blue lips, and the patient may cry out or scream at some point in the seizure. Different types of generalized seizures include a tonic seizure, so this causes stiffening of your muscles. These seizures usually affect muscles in the back, arms, and legs, and can cause the patient to lose consciousness and fall to the ground. Atonic seizures, also known as a drop seizure, cause loss of muscle control, which may cause the patient to suddenly collapse and fall down and subsequently hit their head. Clonic seizures are associated with a repetitive or rhythmic jerking muscle movement. The seizures usually affect the neck, the face, and the arms on both sides of the patient's body. Myoclonic seizures usually appear as sudden, brief jerking motions or twitches of the arm and legs. These are often associated with no loss of consciousness. A tonic-clonic seizure, generally or previously known as a grand mal seizure, are the most dramatic type of epileptic seizures and can cause an abrupt loss of consciousness, body stiffening and shaking, and sometimes loss of bladder control and biting of the tongue. They may last for several minutes. And then there is the absence seizure. This is previously known as a petit mal seizure, often occur in children and are characterized by staring into space or subtle body movements such as an eye blinking or lip smacking. They usually last for about 5 to 10 seconds, but may happen up to hundreds of times per day. So these seizures may occur in clusters and cause a brief loss of awareness. Focal seizures affect a smaller area of the brain and at the beginning involve only one side of the brain. Also known as partial seizures, these patients can experience auras, or again, they may not. Symptoms such as uncontrolled muscle movements may spread from different places on one side of the patient's body. So it may begin on one side of their face and then move down into the hand or the foot of that same side of the body. Focal seizures can be divided into the following subtypes. So there's a focal seizure with impaired awareness. These seizures involve a change or a loss of consciousness or awareness that feels like it's a dream to the patients. The patient may be awake, but they stare into space and don't respond normally to your questioning. This may include rubbing hands, mouth movements, a repetitive certain word, or walking in circles. The patient may not remember the seizure or even know that it occurred. Focal seizures without loss of consciousness occur with altered emotions or a change in the way the patient looks, the way they can smell, feel, taste, or hear, but they don't lose consciousness. They may suddenly feel angry or joyful, sad. Some people have nausea or unusual feelings about how they are feeling, and it's difficult for them to describe. These seizures may also result in difficulty speaking, involuntary jerking parts of the body, such as an arm or a leg, spontaneous sensory symptoms such as tingling, dizziness, seeing flashing lights, and symptoms of focal seizures may be confused with other neurological disorders such as a migraine, narcolepsy, or even mental illness. While on the topic of seizures, we should also talk about the other two types of seizures. These are not the same as the ones that we just covered. A febrile seizure refers to an event in the infancy or childhood of a patient, usually occurring between the ages of 6 months and 5 years. It is associated with a fever and are not considered a form of epilepsy. These can occur in the absence of a CNS infection or inflammation. There is no acute systemic metabolic abnormality that can produce these convulsions, and there's no history of previous afebrile seizures. So these are seizures in children who now have a fever, but who have suffered a previous non-febrile seizure. So these patients, epileptic seizure, they're excluded from the febrile seizure definition. Although the issue is debated, the maximum height of a fever, rather than the rate of rise, may be the main determinant of risk in febrile seizures. A key variable that modulates the impact of fever is the seizure threshold. This varies with each individual, with age and the state of maturity. And the seizure threshold is lower in infants and is modified by certain medications, the amount of water intake that the patient has had that day, electrolyte imbalances, especially hyponatremia, knowing that sodium ion is important in that signal messaging. Viral infections are commonly identified in association with febrile seizures, whereas bacterial infections are infrequent. Febrile seizures are not thought to be viral specific, but rather dependent on the degree of temperature elevation. And viral infections associated with high fever, such as the human herpes virus 6 and influenza, appear to pose the highest risk. A genetic predisposition to febrile seizure has long been recognized, although the exact mode of inheritance is not known in most cases. Among first-degree relatives of children with febrile seizures, 10 to 20% of parents and siblings also have had or will have febrile seizures. Febrile seizures are further divided into two categories, simple or complex, based on the clinical presentations. A simple febrile seizure, the most common type, are characterized by seizures that are generalized, last less than 15 minutes, and do not reoccur in a 24-hour period. Since most simple febrile seizures last less than 5 minutes, a cutoff of 10 minutes has been proposed as a more appropriate threshold in distinguishing between simple and complex. Complex febrile seizures are characterized by episodes that have a focal onset. This is shaking limited to one limb or one side of the body. They last longer than 15 minutes and occur more than once in 24 hours. So these types are great to know, but more important than remembering the difference between the two febrile seizure types is gathering a really good history, and we'll go over that in a minute. Next, we're going to look at eclamptic seizures, and to understand the development of an eclamptic seizure, we need to understand preeclampsia. This is a hypertensive disorder with proteinuria, or the new onset of a hypertension and significant end organ dysfunction with or without proteinuria that generally develops after 20 weeks of gestation or postpartum. The hypertensive criteria include a defined blood pressure of a systolic equal to or greater than 148 millimeters of mercury, and or a diastolic pressure equal to or greater than 90 millimeters of mercury. Severe hypertension is defined as systolic blood pressure equal to or greater than 160 millimeters of mercury, and or a diastolic equal to or greater than 110 millimeters of mercury. Chronic hypertension is that which precedes pregnancy. Gestational hypertension, however, is hypertension referred to with or without proteinuria or the signs and symptoms of preeclampsia related end organ dysfunction, but can also develop after 20 weeks of gestation. There's also HELP syndrome, which is a rare pregnancy complication and is a subtype of preeclampsia, with severe features in which hemolysis, or the breakdown of red blood cells, is present. Elevated liver enzymes and thrombocytopenia are predominant features. Other symptoms of preeclampsia can include severe headache, a change in vision, upper abdominal pain, nausea, vomiting, decreased urine output, and even shortness of breath. So now that we reviewed preeclampsia, eclampsia refers to the occurrence of a new onset, generalized tonic-clonic seizure or coma in a patient with preeclampsia. This includes patients who are experiencing the HELP syndrome as well. Eclampsia occurs in patients with preeclampsia, but sometimes it presents before recognition of the underlying preeclampsia. So if your patient is pregnant and in a tonic-clonic seizure, you don't need the diagnosis of preeclampsia to treat this as an eclamptic seizure. The eclamptic seizure manifests as a generalized tonic-clonic seizure, stiffening of arms, legs, chest, and back. Eventually, muscles begin to jerk and twitch. This is with abrupt loss of consciousness, often associated with a shriek or a scream from the patient. The patients can appear cyanotic during the tonic phase. Once the clonus ends, the patient will seem deep asleep. They can breathe deeply. They gradually awaken, often confused and complaining of a headache, and most recover to full responsiveness within 10 to 20 minutes. The precise cause of eclamptic seizures is not clearly understood. Time of presentation for eclamptic seizures, approximately 60% of eclampsia causes occurred antepartum, 20% occur intrapartum, so during birth, and 20% occurred postpartum in a systematic review when we researched on UpToDate. And amongst our postpartum cases, approximately 90% occur within 1 week of delivery. So we have been dispatched to a patient in an active seizure. So let's discuss our role in caring and managing the seizure patient. So like any other patient, where do we start? We're going to start with the ABCs, kind of hand in hand, right? Is the airway patent? Do we need to support the patient in any way? We can look at their oxygen saturations. Better yet, we can look at their capnography. This is going to be a better picture of the patient's hypoxic state. We can also consider how best to oxygenate the patient if needed, but we're also going to be mindful of the precautions we're still taking with the appropriate PPE. While one partner is doing that, another could be asking a bystander, family member, when did the seizure start? How many seizures has the patient had? Did you notice any changes in behavior prior to the seizure? How long has this seizure or all seizures lasted? What did the seizure look like? We can check and see if the patient is incontinent. Have you been able to pinpoint triggers or the patient noted any triggers? And is the patient on any medications? We're going to assess vital signs the best we can if the patient is still in an active seizure. And when it comes to IV access, it can be difficult to establish an IV during seizure. If this is the case, we can wait to initiate the IV until after you have treated and stopped the seizure by other routes of medication administration. We're going to ask the witness if the seizure, did it start after a fall or a form of trauma? Is there medication suggesting an infection, recent medical history, surgery suggestive of an infection? Are there any bleeds? If there's any bleeding present from the fall or other injuries, we want to ensure that we address that as well and stop all bleeds. And does the patient have an increase in temperature, especially those pediatric patients at risk for febrile seizures? And please do not ever forget the glucose. We need to rule out a treatable, reversible cause of a seizure. Now remember those mixed signals? When we talked about the neuron signals, the imbalance of excitatory over inhibitory, and needing to restore that balance, well, this is where midazolam comes in. What does midazolam do? Well, it binds to a specific benzodiazepine receptor on the postsynaptic GABA neuron at several sites within the CNS. Enhancement of the inhibitory effect of GABA on neuronal excitability results by increasing neuronal membrane permeability to chloride ions. This shift in chloride ions results in hyperpolarization, a less excitable state, and stabilization. So benzodiazepine receptors and effects appear to be linked to the GABA A receptor. So by administering midazolam, and it's binding to the GABA inhibitory neurons. It replaces the deficient neurotransmitter GABA, and it brings back a balance between the excitatory and inhibitory effects of the neurotransmitters. So when we look at the administration of midazolam, which is the best route? Well, to answer this, we need to first look at the patient's current clinical presentation. Are they currently seizing? And if they are, then let's choose the best way to effectively administer a dose of midazolam. This could possibly mean an intramuscular or an intranasal route, the easiest due to the current clonic state. Or is the patient currently experiencing a focal seizure or even in the postictal state? And we have the ability to use vascular access on the arms. Then let's try this sooner than later. I'd rather have and not need than need and not have. When midazolam is given IV, it has an onset of 1 to 3 minutes. The duration is up to 2 hours. It is rapidly absorbed and 100% bioavailable. When we give midazolam intramuscular, the onset is 5 to 15 minutes, can last up to 6 hours, and is 90% bioavailable. When administered intranasal, the onset is approximately 10 minutes, lasting about 25 minutes and only 40% bioavailable. Considerations for administering midazolam intravascular is a very slow push. Consider diluting midazolam for administration. Here we have a 10 mg per 2 ml vial. Let's add it to 8 milliliters of normal saline. That will give you a 1 mg per ml concentration that can be given over a span of at least 1 minute. We want to avoid too rapid of administration because this can cause respiratory arrest or hypotension. And we want to consider titrating that IV dose to clinical effect. It's always better if we can administer the medication to effect as opposed to administering the entire dose and possibly seeing unwanted effects. Again, I'm talking about that respiratory depression after an entire dose of midazolam is given. We also want to use caution in patients that are on or have ingested other CNS depressants. This will include narcotics, alcohol, and other benzodiazepines. Be prepared to ventilate these patients if the patient becomes apneic, and a paradoxical reaction can occur, particularly in the geriatric and pediatric populations, and with patients who have a history of excessive alcohol abuse. When we look at treating a febrile seizure, what's the difference? Well, there are age limits, so some of the youngest patients may not be in a category that we can administer medications to. Doses will be based on the patient's weight, so let's utilize that Broslow tape or ideal body weight calculation if the caregiver is unable to give us the patient's weight. And if the patient or caregiver has not done so already, and the patient is still febrile, let's consider giving them an antipyretic. So this is either acetaminophen, ibuprofen, either are acceptable choices. Just consider asking if one has already been given and which one. If it's been at least 2 hours since one is given, then let's consider administering the other. Now on to the management of eclamptic seizures. Few key principles. If the seizure is witnessed, let's maintain that airway patency. Let's try and prevent any aspiration, and let's roll that mom onto her left side. Get the weight of the fetus off of that inferior vena cava. And then let's also prevent maternal hypoxia. We need to consider that if the mom is hypoxic, so is the fetus. But again, protection of mom is always more important. We want to prevent any recurrent seizures, and we want to get the patient to evaluation for prompt delivery. So this is transporting to the closest emergency department or even transport to a delivery center, which could be a subsequent interfacility transfer. During transport, maternal oxygenation and protection from trauma is most important. Again, placing the patient on the lateral position if possible. We want to lift that fetus off that inferior vena cava, and administering supplemental oxygen is a treatment of hypoxia and hypoventilation during seizures. Now for the anti-seizure medication of choice. This is magnesium sulfate. Not only is it used for eclamptic seizure activity, but it's also used as seizure prophylaxis when preeclampsia has been identified as well. The exact mechanism of action is unknown, but what we do know is that it decreases the amount of acetylcholine released at the end plate by motor nerves, and it blocks the peripheral neuromuscular transmission. This stabilizes the excitable membranes in the CNS, and it produces an anticonvulsant effect. It's also thought to cause vasodilation of constricted cerebral vessels, reducing cerebral barotrauma. When magnesium sulfate is administered, via IV, its onset is immediate. It lasts approximately 30 minutes and it is 100% bioavailable. The medication document lists magnesium sulfate as a high-alert medication, so please remember to do your double check on your meds. A consideration when administering magnesium sulfate for preeclampsia and eclampsia is a slow infusion over 15 to 20 minutes, and this is to avoid magnesium toxicity and respiratory muscle weakness. Being the anti-seizure medication of choice, treatment is primarily directed at the prevention of recurrent seizures rather than the control of initial seizure, since the initial seizure is usually a short duration and may occur in the setting where an IV access or the drugs are not readily available. Approximately 10% of patients with eclampsia will have repeated seizures if managed expectantly. There is a universal agreement that patients with eclampsia require anticonvulsant therapy to prevent recurrent seizures and the possible complications of repeated seizure activity, which could be neuronal death, rhabdomyolysis, metabolic acidosis, aspiration, pneumonitis, neurogenic pulmonary edema, or respiratory failure. Evidence of magnesium sulfate's efficacy is based on a randomized trial which demonstrated that it reduces the rate of recurrent seizures by 1/2 to 2/3 and the rate of maternal death by 1/3. A series of systematic reviews reported magnesium sulfate was safer and more effective than phenytoin and diazepam for prevention of recurrent seizures in eclampsia. Other advantages of magnesium sulfate therapy were its ease of administration and lack of sedation. An additional benefit is that in utero, exposure to magnesium sulfate therapies decreases the risk of cerebral palsy, severe motor dysfunction in offspring born before 32 to 34 weeks of gestation. In 2 international multi-center trials, there were 905 patients with eclampsia that were randomly assigned to receive either magnesium sulfate or diazepam, and another group of 775 patients with eclampsia who were randomly assigned to receive either magnesium sulfate or phenytoin. Primary outcome measures were rates of recurrent seizures and maternal death. Magnesium sulfate was significantly more effective than either diazepam or phenytoin. Seizures that happened and that were allocated diazepam were 13 and 28% respectively, and patients allocated to magnesium sulfate therapy had 1/3 the rate, or 6%, of recurrent seizures of those allocated phenytoin, which was about 17%. So in this arm of the study, the magnesium sulfate group was less likely to be admitted to intensive care, less likely to require ventilatory support, and less likely to develop pneumonia compared to those in the phenytoin group. So this is why we choose magnesium to treat eclamptic seizures. If there are any questions at all, please feel free to reach out to our clinical team in the West Zone. Here are all our numbers. We are all available at any time when you have questions. I'd like to thank you for joining us today and have a great day.